Awesome. Welcome and thank you all for joining us today for the Missouri Eliminate Tobacco Use Initiative's webinar on tobacco and ACEs. Dr. Everett, can I turn it over to you to introduce yourself briefly and then share our speakers for today?
Hi, yes, and welcome everyone. I'm Kevin Everett. I am a faculty member in family and community medicine at the University of Missouri, and have had long-standing interest in tobacco control, tobacco research, and addressing vulnerable populations related to tobacco use. It's my pleasure to be director of our Missouri Eliminate Tobacco Use Initiative. It's an initiative that is focused on addressing best practices of prevention, policy, and cessation on college campuses, as well as within health systems, because there are two target audiences and communities. I'm really excited today to offer this webinar with some expert speakers to some thought-provoking strategies on addressing tobacco use on college campuses. We'll have three speakers sharing this presentation: Taslim, Aniela, and Amy. A little bit about Taslim Van Hattum is that she is a Senior Director of Practice Improvement at the National Council for Behavioral Health. She has directed a variety of national health equity initiatives, kind of looking at the intersection of public health, behavioral health, so mental health and addiction as a primary example. Over 15 years of experience leading behavioral health and social service integration, both with community-based primary care practices as well as school-based practices. We want to welcome her, as well as welcome Aimee Rachel, who is has special training in, I'm sorry, my screen is not coming up. She's has special training in trauma-informed care. She has a master's in social work, and that training has led her to be able to help local, state, and federal first responders, even court personnel, to be able to offer training that is trauma-focused on cognitive behavioral therapy. And she's also, interestingly enough, certified in eye movement desensitization and reprocessing therapy, which is a very unique approach to assisting people with trauma. And finally, additionally, we have Aniela Brown, who initially was a clinical intern with the organization and then has worked on a variety of approaches to addressing vulnerable populations, increasing vaccinations, and a host of experience in program development, coordination, integrating these treatments to a variety of organizations. Thank you all for agreeing to lead this, and then thank you all for signing up. We are going to have a chance for Q&A at the end, and Michelle McDowell will be monitoring chat and ready at the end of the session to be able to present questions to our presenters. Taslim, I'll turn it over to you at this time, and thank you so much for joining us.
Thank you so much, Dr. Everett, for having us today, as well as the fantastic folks at the Missouri Eliminate Tobacco Use Initiative. So honored to be here. Again, Taslim Van Hattum, she, her, hers, with the National Council for Mental Wellbeing. And just a little bit about the National Council, so you're grounded in what we do, but we are a national advocacy organization based in Washington, D.C. Excuse me, can you all hear me okay? Great. Based in Washington, D.C., representing behavioral health treatment facilities, but that would be mental health and addiction treatment facilities across the United States, really focusing on advocacy and policy, as well as a number of other initiatives. Many of you might know us through our mental health first aid program. In addition to, I'm going to You can go next. I want to welcome our partners as well to introduce themselves.
Yes, thank you. Thank you to the University of Missouri for having us. And it's always an honor to work with our partners at the National Council on Projects. Just to give you a little information about the Texas Association of Community Health Centers, or TAC for short. Our organization, of course, was formed in 1983, and we're a nonprofit membership organization to 75 health centers across the state of Texas. TAC serves really as this link between federal, state, and our local entities, providing healthcare for the most vulnerable populations here in Texas. In 2020, TAC served 1.6 million patients in 133 counties across the state of Texas. In 2019, TAC began a trauma-informed care program, and currently we have 28 health centers undergoing that trauma-informed care transformation. We recently welcomed Aniela Brown to our TIC team. She has a wealth of knowledge and experience in trauma-informed care. And she's taken the lead really on our trauma-informed care and tobacco initiatives. So I'm going to turn this presentation over to her, and really to begin our conversation on why we're even talking about trauma and tobacco in the same conversation.
Thank you, Amy. So just to ground us in what our learning objectives are today. So by the end of the session, we want you to be able to recognize why individuals with trauma histories have disproportionate tobacco use, describe trauma-informed evidence-based interventions, reflect on the role that the University of Missouri and your allied health professions, and really as an entity, can play in promoting these trauma-informed practices in your tobacco cessation initiatives. And then next slide. So as we're going to be talking today, self-care is going to be very important. Some of the material that we will discuss today could be difficult to hear, so we just strongly encourage you to take care of yourself, go get a glass of water, take a break, turn your camera off. So really be present, and we encourage you to obviously participate, but and ask questions, but really take care of yourself during the course of this presentation. Next slide. Taslim.
Great. So just a few quick notes on language and terminology. We like to just level set in our conversations around this. At the National Council for Mental Wellbeing and the National Behavioral Health Network for Tobacco and Cancer Control, we're really committed to changing the conversation specifically around mental well-being to be that of the most inclusive we can be, making sure that we're highlighting mental health and substance use challenges, but always both starting, leading, and ending every conversation with the possibility of recovery and a recovery orientation. So you'll see in much of the way that we're framing things today, that so much of this is rooted in individuals' ability to recover and be incredibly resilient. I also want to note that when we're talking about tobacco use today, we're talking about commercial tobacco use and not talking specifically about sacred or traditional use of tobacco by some American Indian or Alaska Native communities. Next slide. Great. So I think for today, I wanted to just get us grounded a little bit more in what we're talking about around health and decision-making, specifically before Aniela and I really jump into a little bit more about trauma-informed care and trauma-informed tobacco, tobacco cessation, really. So if we can go to the next slide. So it's really worth noting that oftentimes when we're programming around tobacco use and tobacco cessation, our first instinct, particularly in healthcare settings or addiction treatment settings, is that of individual health behaviors, right? You'll see here on the left-hand side what I'm talking about, that traditional addiction discourse and programming. And today we're going to also really encourage you to start thinking about this from that larger health equity and social determinants of health perspective, really understanding that, of course, seeking to intervene around tobacco use with individualized personal behaviors is really critical. But oftentimes knowing that only about 30% of our health behaviors end up being, or only about, or within the determinants of health, only about 30% are influenced by individual health behaviors. We want to really also ask ourselves to zoom out and be thinking a lot more intentionally about the role that clinical care, that access to care, socio and economic factors, as well as the physical environment plays within tobacco use. And then also when we're starting to think about trauma and trauma-informed care and how those lead to health outcomes. Next slide. So we'll go through a little bit of some of the reasons why individuals start smoking. And this is not every single reason, as many of you know, right? There's some, but when we really think about what causes a significant amount of individuals to start using tobacco, it's targeted and predatory marketing by big tobacco, the high rates of ACEs or trauma exposure, which we're going to be talking a little bit more in depth about today. Limited access to high quality care. So remembering on that slide we just looked at, that is a social determinant, family and social influences, delays in care, lower quality of care. And then if there's any that I missed here, I really welcome you all dropping them in the chat box as we're talking today, as you really start to think of what are some of those individual reasons. Now, these cover the largest bulk, and you'll see here that one of them is that high rates of ACEs or trauma, which is why a lot of what we're going to be discussing today is that complex interaction. So next slide. But before we go into that, you saw in the previous one, we just talked about the determinants of health. And I wanted us to also then focus in a little bit more on college-aged use and think youth. College-aged use of tobacco and college-aged youth, excuse me. So really thinking about beyond just those individual tobacco use behaviors, what also is influencing health outcomes, tobacco use and tobacco use outcomes. And so here we've layered a number of the other college age determinants of health, particularly as you're starting to think about a holistic health and wellness intervention with young people to both address tobacco use, but think about that within a larger context of care and services. So next slide. So more than anything, and I know before we really start digging deep into a little bit more around trauma, ACEs or adverse childhood experiences, and then the complex interaction with tobacco, we want to just ground in that social determinants are not destiny. And similarly, exposure to adverse childhood experiences are also not destiny. We want to ground in, as I said, really knowing that recovery within mental health and substance use is possible, and really grounding in resiliency as an outcome. So I'm going to make sure to talk about that a little bit more as Aniela and I run through some of the other key and important parts around trauma and stress, adversity, and adverse childhood experiences. So next slide. Great. So I believe, Aniela, you want to run us through some key concepts within this space?
Yes, absolutely. So really, like Taslim said, starting the discussion around trauma-informed approaches, we want to make sure that we have some basic definitions or key concepts down as we move forward. So the first one is about trauma. So trauma is one possible outcome of exposure to adversity. It can occur when a person perceives an event or set of circumstances as extremely frightening, harmful, or threatening, either emotionally, physically, or both. And it has lasting adverse effects on the individual's mental, physical, social, emotional, or spiritual well-being. Toxic stress is another big concept we'll talk about, and that can occur when an individual experiences adversity that is extreme, long-lasting, and severe. So think of chronic neglect, domestic violence, severe economic hardship, without adequate support from a caring adult or supportive network. And those adversities can overactivate the stress response, wearing down the body and the brain over time and actually changing our neurobiology. And we'll get a bit more into that later. Childhood adversity is a broad term that refers to a wide range of circumstances or events that pose a serious threat to a child's physical or psychological well-being. Childhood trauma is associated with problems across a multiple domains of development. However, trauma affects each child differently depending on his or her individual like genetics play a role, family, environmental risk, and protective factors. And then lastly, adverse childhood experiences. We're going to jump right in and get into that next. So next slide. Okay, so three components of trauma. So this is really, this definition is pretty comprehensive, but let's break it apart a little bit more to see what we're really talking about. So traumatic events such as a family or social violence, assaults, disaster, wars, accidents, predatory violence, they really confront people with such horror and threat that it may be temporarily or permanently altering to one's capacity to cope. It affects their biological threat perception and even can change the way an individual views themselves. To begin, let's look at the 3 E's highlighted in this definition. So the events, the experiences, and the effects. So effects, we're focusing on the events, we're focusing on the events that, because this is the place where the trauma actually took place. So we look at the environment to begin to really piece apart where the trauma took place. We look at it as the place that caused the trauma, not as a defect in the individual that has been affected by the trauma. And trauma can be caused by events that the individual doesn't even remember, such as events that occur in early childhood. Those events can be well-intentioned and necessary, such as medical procedures. They can be caused by an event that didn't happen to the person, but to a group that he or she or they identify closely with, as in slavery, the Holocaust, a genocide. Over time, those chronic stressors can accumulate and cause trauma. And some of the questions that we want to think about is, what was the proximity to the event, to that trauma? And did the event happen to them, to their family, or to their community? The experience is because we know that not everyone experiences a trauma in the same way. So questions that we want to think about could include how the individual experienced the event. Did they witness it? Did they hear about it? Did they experience it themselves? And was the event caused by someone who was supposed to protect them, or was it a stranger? And lastly, the effect. What are the effects that we can see versus what we can't see? And that's really going to be important as we move forward in our conversation. Oftentimes we think about the effects, and that's really when we think about trauma, but it could be a combination of all of these things. And it's really important that those providing that day-to-day support and care become more trauma-informed and understand the impact of trauma has on behavior development and those relationships. So next slide. Okay, so getting into our stress. So a critical part of the conversation about trauma requires us to think about stress. And when we stress can be a good thing. It can be a bad thing. We know on college campuses, stress is everywhere, but we really want to talk about the fact that stress exists on a continuum. And when we hear stress, we generally think of it as a bad thing, but there are things that, and we want to avoid, but that can be true, but there's also at the core reasons why stress exists. And we can look a little bit more into this. So positive stress or eustress is a moderate psychological stress that can be beneficial. So it usually motivates and focuses energy for the short term, is perceived to be within a coping ability, feels exciting, and it can help improve in performance, such as like a sporting activity, for example. Acute or tolerable stress, it can develop after exposure to one or more traumatic events. So let's say you are on a hike, this is a great example, and you run into a bear in the woods. Sounds terrifying, right? So that would be pretty stressful. Your body would start pumping out hormones, and you'd shift into this fight, flight, or freeze mode to protect yourself. So maybe we decided that we were going to try and fight the bear, and you start doing all of the make yourself really big, and you're going to scare off the bear. So that's one approach. Or you go into the flight mode and you run away, or maybe you crouch down and you try and play dead. Maybe that could be a response. So those stress symptoms develop quickly, but do not usually last long and are mitigated by positive relationships. So you come back after the experience, you tell your family, this was crazy, listen to what happened to me today, and you can process and work that out. So you still have that response, but you can mitigate it a bit with working with those around you. But really, the toxic stress is that excessive or prolonged activation of response systems as a result of sustained traumatic event or stressors. So going back to that bear example, or insert another traumatic event, right? What if the bear stuck around? What if you were on long-term camping exercise, or you had to see that bear come back every day, or the bear really, really hurt you? Then that would become a toxic stress, and your body might be activated all the time. So even things that remind us of a bear will cause our bodies to react in that similar way. Toxic stress can damage learning, behavior, and health across the lifespan. And this is really where coping mechanisms and maladapting coping, such as smoking, can start. Next slide, Taslim.
Great. So, we talked a little bit, Aniela talked a little bit about stress and trauma and how they live on that continuum. And I want to talk about this just a little bit more in the context of brain development, particularly because we're going to be talking about some specific ages within brain development later on in the presentation, but also really understanding that stress affects decision-making and processing and regulation and so much more over time. So I'm not going to get too deep into it, but I want to talk a little bit about the basic brain science that's presented here, right? Our brain mediates everything from our thoughts to our feelings, our actions, and our connections to one another and the outside world, right? And so helping understanding some of these basic neuroscience principles can really help us understand both ourselves, but also others in the moment and in context, particularly around health behaviors, and then help us to understand how to build our own and other individuals' wellness and resiliency. So this is actually the work of Dr. Bruce Perry, a very profound trauma neuroscience expert. I would highly encourage you looking at some of his work. And really this hierarchy is showing you how our brain is developed and it functions, right? And the brain stem, of course, comes online first. We don't survive, as many of you might know, birth without a functioning brainstem. And of course, it controls everything in our body, from our temperature to our heart rate, to our reactions. And then as we develop throughout childhood, more complex areas of the brain develop and come online. And as more come online, the brain develops until we get to this sort of crowning achievement of what we might understand of being human, which is the full development of our prefrontal cortex, which actually isn't fully developed until the age of 25. So if we go to you can see here, just as you develop, can we go back one sec? Really where you see that hierarchy of brain developing as you move up to a fully developed prefrontal cortex. And I really encourage you to look at this when you're also thinking about age and development, the way in which to think about matching interventions and conversations to that of staged brain development within individuals, right? So next slide. Back a little bit also to thinking about that as both brain development, but also the activation of this stress response system. Again, remembering that stress and trauma live on this continuum and impact health behaviors, including tobacco use behaviors, right? And so that stress response system is housed in our lower brain. So all the information that we're receiving from the outside world and our internal mechanisms go through this stress response system. And it's when we determine whether we are threatened or safe after it goes through that system. right? It's some, and if something makes you feel threatened, there'll be a variety of different responses that you can essentially recruit in order to help you stay alive, right? And we often reference those as fight or flight or freeze responses. But essentially, the locus of control moves from the higher region of the brain to the lower region of the brain, depending on the level of threat. And this is also really important because each region of our brain manages and processes information in a really different way. And these internal states and really affect everything you do, including the way you think, act, and feel. It's exceptionally important when we're thinking about interventions and where the stress response system is when interventions are being enacted, right? Are you calm? Are you alert? Are you in alarm or a fear state, right? And thinking about as an individual's brain moves into a fear or terror state, that individual or you are functioning from a lower region of the brain and no longer able to think before you act, or many of the brain processing or decision-making skills are no longer fully present. So your sense of time shrinks, your sense of threat might look very different. And so we know that for those who have experienced early trauma, adverse childhood experiences, the brain often develops an oversensitive stress response system in which an individual will default to survival mode even when there is no imminent threat present. So let's go to the next slide so that we can just also understand a little bit more about what those adverse childhood experiences are and how they play out in our community and young people.
Thank you. So the Adverse Childhood Experiences Study, or ACES, was a study done in the 90s by Dr. Vince Folletti and Dr. Rob Anda. And so Dr. Folletti was a medical provider in San Diego, California with Kaiser Permanente. And he was approached to do a weight loss study. And you're talking weight loss for individuals with severe obesity. And so he started this weight loss clinic. He agreed. He had major success. So people were losing 100, 200, 300 pounds. Great success. This was great. How do we move forward? But then little by little, he started to see individuals who started to gain the weight back. So they were kind of confused. What's going on? We had these great outcomes. So they started to do a little bit more digging and started asking questions. Come to find out that a lot of the individuals, if not the majority of individuals who were gaining the weight back, had some sort of exposure to adverse trauma, adverse childhood experiences early in life, and the weight or the weight that they had gained was not a risk factor for them. It was actually a protective factor. And by that, we mean that it was their armor. And so whether it was individuals with experiences on sexual abuse who were then objectified, and this was a protective coat essentially that they were wearing. And then little by little, as they lost weight, they started to get more attention. This was sending up red flags and activating them for those past experiences. And then they started to gain that weight back. So this really, they started to, he recruited another physician, Dr. Rob Anda from the CDC. They started looking into this a little bit more. And what they had found is there were 10 different types of childhood trauma that they really started to come up in conversation. So 5 were personal: physical abuse, emotional abuse, sexual abuse, physical neglect, and emotional neglect. 5 were related to family members and that history. So maybe a parent who struggled with substance use, a parent who was a parent who was a victim of domestic violence, a family member who was incarcerated, a family member that was diagnosed with a mental illness, and the disappearance of a parent through divorce, death, or abandonment. And now for the ACE study and the screener, each one of those adversities counts as 1 point. And so what they were able to see is the increase in the number of points essentially increased the chance that somebody was going to have adverse outcomes later in life. And so this triangle image has changed over the years. It started initially with the adverse childhood experiences being at the bottom, but importantly, and we'll talk about that a little bit more, is the social conditions and local context, and then the general generational embodiment and historical trauma were later added, which was incredibly important. So what they found was ACEs are strongly associated in a dose response, so a one-to-one relationship with serious health outcomes that are present, and they are responsible for the overwhelming majority of things that we see in society today. They are highly prevalent, so 2/3 of the respondents in the ACE study reported at least one of those adverse childhood experiences, and 1 in 8 reported 4 or more. And that ACEs affect all communities, and we'll discuss that in the next slide. Next slide, yeah. So this image from the CDC illustrates the various areas of life and potential consequences of ACEs. So I want to call a specific note. So there have been a number of studies looking at how ACEs are connected to different health outcomes, but particularly for our conversation today, alcohol, tobacco, and other drug addiction, there's a connection, depression, anxiety, and other mental illness, high-risk sexual behavior or activity, STDs and unintended pregnancy, intimate partner violence, so both a perpetration and a victimization, lung cancer, obesity, self-regulation and anger management problems, suicide attempts, and work problems. So that could be absenteeism, productivity, and on-the-job injury. So those are just a few to keep in mind. Next slide. Okay, so like we had said, so the original ACEs study was conducted among a population that was mostly Caucasian, middle class, employed, college educated, and privately insured. And so it was a large study, over 17,000 individuals. And subsequent, so if we found high rates of adversity among that population, and subsequent studies have found even higher prevalence of ACEs in individuals who are low income, of color, justice involved, part of the LGBTQ community. And really another additional layer to this that's important is since that first study was published, there's been an expansion of those 10 things. So really a coupling of social determinants of health and ACEs. So looking at poverty, discrimination, community disruption, lack of access to economic mobility and capital, deportation, immigration status, involvement in the foster care system, discrimination, racism, and then witnessing community violence. So these have all been found to be wildly important and kind of expand our thinking of ACEs. Next slide, and Taslim.
Great. So this then really, let's talk about really getting at the intersection of these two areas, right? That relationship between tobacco and trauma. And I say this as a practitioner who worked for many years within the trauma space and then many years within the tobacco control space. And oftentimes these two topics weren't tied together, right? But then when we really start digging into this, we see that there's a very strong relationship between the two. And I'm going to jump into the exact relationship between the dose response relationship between tobacco and adverse childhood experiences. But in the more general sense, tobacco and trauma are deeply interconnected, right? And so what we know is that the more adversities an individual faces, the more likely they are to start smoking and the less likely they are to quit. And then ACEs particularly is associated with 4 things. That's the more likely you are to smoke, the amount that you are likely to smoke, which is a greater amount. So the early rate of initiation, and then the duration of your tobacco use. But what we know is across the United States that about 14% of individuals without any form of adversity smoked. And then, of course, as we add in different layers of disadvantage or adversities, what we see is that smoking rates increase, rising to about 58% of all individuals who do smoke combustible commercial products, having some form of adversity diversity, and those are defined by 6 socioeconomic or health-related disadvantages in our country, that of unemployment, of poverty, of low educational achievement, disability or different ability status, serious psychological distress, and then of course heavy drinking, and thinking about both of those as really related to behavioral health. So when we dig into that a little bit deeper, let's go to the next slide. Let's talk specifically about how a higher ACEs score means increased tobacco use. And Aniela talked a little bit about this, right? That dose-response relationship. But I want to walk you through this chart so that you understand how that dose-response relationship works specifically with tobacco use. So this chart will help you to understand how that really works. So if you can, imagine that there are 100 people who are all ACEs free. They have no exposure to adverse childhood experiences, and about 6 of them will smoke, right? You can think of those people who will smoke whether or not there's ACEs in the world. Their smoking can be caused by genetics. It can be caused by access to cigarettes, right? A parent who might have smoked, learning how to smoke as a young person because the adults around them smoked. Right? These are also those individuals that are more likely and tend to quit when presented with information and interventions around the negative consequences of tobacco use. And that has really, we've seen the successes of that, particularly in a public health context, right? Now, imagine of those 100 people, 3 of them, so if you look at them, 3 of them who have, or now imagine 100 people who have had 3 ACEs, right? And that's going to be your second bar. So 11 of those 100 people will automatically have an increased risk of tobacco use owing to being exposed to 3 ACEs, right? And so then you can see within the next one, the risk of smoking increases with exposure to ACEs. So on this next line, you'll see that 17% or 17 of 100 people will have an increased risk of tobacco use if they have been exposed to 7 or more ACEs. And the best way to understand this is simply that the risk of tobacco use accumulates as the ACE score increases, right? The proportion of smoking that is attributable to ACEs is tied to this change in risk, right? And so when we think about smoking is responsible for over 400,000 deaths each year in the United States, cancer deaths, about 30% of all cancer-related fatalities, and about 80% of all deaths from heart disease and COPD in our country. And then we think about where the increased risk is. Part of our conversation today is where that early initiation and prevention can play a role. So next slide. Now, the reason why I mention that is because what we also know about exposure to adverse childhood experiences is, like I said, it does impact overall tobacco use rates, but it deeply impacts the age at first use. And so increased exposure to adverse childhood experiences puts young people at a higher and increased risk of initiating tobacco use. So as with alcohol use and many of the other subsequent health conditions of adverse childhood experiences, ACEs increase that risk of early smoking initiation before 18. So about 21% of those with 4 or more ACEs reported early initiation of tobacco use, compared to only about 5% of young people with no ACEs. And then, of course, as I said, ACEs also lead to the duration of smoking. So the longer rate of tobacco use, heavier smoking, and then have a real actual combination risk with that of COPD as well as resultant adult depression. So let's go to the next slide. I just want to show you what this looks like by comparison. So of course, the rate of adverse childhood experiences and smoking prevalence as compared to individuals with no adverse childhood experiences and daily smoking. So I think when you see it here, it really helps you understand how increased that risk is, and really the association of that dose response relationship. Right? And then we can go to the next slide. Really the number one thing I think that many people, particularly if you're not doing clinical trauma interventions, or you might be doing health education, you might be doing youth programming that employs tobacco use interventions in a variety of different curriculums or smoke-free college campuses, many other things that might not be direct cessation care. Thinking about adverse childhood experiences as simply increasing the likelihood of high-risk health behaviors and those leading to longer-term health consequences. We know that in addition to just adverse childhood experiences, reports of trauma exposure in early childhood are associated with a twofold increased risk of smoking. And so I say this because even if you're not having young people who are specifically saying they have had an exposure to an adverse childhood experience, those early years within adolescence as well as young adulthood are still critical years where trauma exposure does occur and is associated with that twofold increased risk of tobacco use. We also know that individuals who are exposed to trauma and develop a PTSD diagnoses smoke more intensely. And then we also know that about 73% of these individuals smoke more than a pack of cigarettes a day if they have a PTSD diagnosis. So we know that that exposure to adverse childhood experiences and then potentially other traumatic exposure in young adults leads to these healthier risk behavior. I mean, the less healthy risk behaviors, and then the long-term subsequent health consequences. So based on that, I really want to also take some time to transition to Aniela to really talk about what does that mean, though, in the context of trauma and trauma-informed care. And I say that holding that it's intense to have spent the last 10 minutes really talking about adverse childhood experiences and trauma exposure, right? And knowing that we have science that shows us how absolutely significant the effects of trauma is on young people all the way into adulthood. And yet we also know that, this is not necessarily all young people's destiny, and their exposure to adverse childhood experiences and trauma is not the only, we know that they've also been exposed to incredible strengths and resilience building activities and far more supports than any of us realize. So I want to also transition to Aniela to talk about what this looks like in the context of trauma-informed care.
Thank you, Taslim. So we can actually go into the next slide after that transition. So masks, we have our universal precautions. So masks recently have been synonymous with protection in our communities, but we want you to think a little bit more broadly about the concept of universal precautions. And so while many of you remember, have heard that it originated with the protection of healthcare workers and first responders in the wake of the HIV epidemic, the applicability to our topic today is critical. So just like for many illnesses or infections, you can't always tell by looking at someone if they are suffering. And we know that ACEs and trauma are extremely common, and there's no group of people that are exempt from potential repercussions. So we just really, to get started with our conversation, really encourage the application of universal trauma precautions as a way of interactions with all people. And as we continue with our presentation, we'll discuss more about what this could potentially mean for your work with university students and with broader applicability to all communities. Next slide. So firstly, we want to talk about, we talked about the ACES study, and really that's at the root of trauma-informed care. But when we say trauma-informed care, TIC, what do we mean? So it's a strength-based framework that helps to provide us with the opportunity to look at people differently, look at communities differently, and engage and try and promote that resiliency and healing moving forward. So there's really 4 R's that are critical components of TIC: realization, recognition, response, and then resisting re-traumatization. So in the interest of time, just give you a high level overview of these. So by incorporating a trauma-informed approach at all levels with all people, you really want to make sure that everybody has that foundational information, like what we're doing today, that the realization that trauma is pervasive, it doesn't, it impacts all communities, and it's just all around us. So that realization and that application of universal trauma precautions is really that first level. It's not just relegated to behavioral health services, but that there are lots of different areas that can be impacted. And there's really empowering you to know that there's lots of ways that you can help support your students and faculty and staff. People within college campuses can begin to recognize the signs of trauma. So these signs could manifest by individuals seeking or utilizing services through observations or behaviors by your students and staff and faculty, and then to begin to recognize these signs through screening and assessing, workforce development, and supervision as well. We realize the pervasiveness of trauma, like we've talked about, and that recognition of the signs and symptoms helps us to be able to respond a bit more appropriately to those actions. So this at a university, it could be accomplished through staff training, like what we're doing today, budgeting that supports ongoing training and professional development, leadership, recognizing the role of trauma in the lives of students, faculty, and staff as well. And lastly, we want to really resist re-traumatization of students, faculty, and staff. So it's critically that university systems look at policies, practices, procedures to ensure that we're not unknowingly causing re-traumatization through any of these areas. And this is, so we can move on. The discussion is far from exhaustive, but these principles really get at our next thing, that it's really a paradigm shift, thinking about the question, what's wrong with you? So that's students, faculty, and staff, to what happened to you. Next slide. So our guiding principles, so this comes from SAMHSA, and they really are working, this is can be broadly applied. So we're looking at how to promote physical and psychological safety, how to build trusting relationships with others, offering choices when possible, collaborating with one another, supporting and fostering agency through empowerment and providing opportunities for peer support. And lastly, understanding the role trauma plays in society, particularly for historically marginalized communities. And as you begin on your trauma-informed journey, these pillars can serve as a fantastic foundation for rethinking how you engage with students and one another. So you can incorporate these terms into job postings, program descriptions, and practice guidelines as really a first step. And then we, in the interest of time, we're not going to provide specific examples, but the slide deck will be available for you to really start to think about those specific examples. So we can fast forward through a number of these different slides. A little preview of what you'll get coming out. So now we're going to transition into our last section for the day, focused on the students that you serve. So we know that you work with college students every day, but particularly for our discussion, we want to briefly review developmental stage and what's really important for the student body that's included. And these points are really important to keep in mind as we think about how we support tobacco cessation programs and other substance use initiatives. Next slide. So particularly for your college students, most of them may fall between the ages of 18 to 24. And that period is really known as late adolescence, young adulthood, or even emerging adulthood. And this is marked by a few really key points. So there's an adjustment to a new physical sense of self. So at that point, most hormonal and physical changes have generally started to regulate. Sexual identity, intimacy, and relationships are coming to light as well. There are significant changes in their ability to think abstractly during this period. So that particularly means for themselves, others, and how things fit together. This period can also be marked with a greater sense of a greater ability to consider different perspectives, and could result in increased empathy. And really, though, this period is marked by an attempt to answer the question, who am I? How do I fit into the world? And with whom do I connect with? And we want to acknowledge that many college students do fall outside of this developmental stage, but the trauma-informed care presentation that we provided in this background is going to help you to be able to best serve your adult learners, whether it's undergraduate or graduate as well. Next slide. So a couple of highlights, while some of these may seem intuitive, particularly for the connection with tobacco use, we know research has found that self-efficacy and confidence do serve as protective factors for individuals to help prevent them from starting smoking in the first place. Peer and family attitudes towards substance use really do matter. So this has been found to either be a negative attitude, or which results in less tobacco use, or a more favorable attitude, which results in more use. So particularly, research has found a significant association between reporting a higher number of ACEs and perceiving parents and peers as having more favorable attitudes towards substance use. So that's kind of empowers people, but then also is kind of scary at the same time. And then for parents, caregivers, guardians, and educators, really you serve a huge role in potentially reducing exposure to childhood adversity. So really creating these trauma-informed environments that can reduce those short-term effects and the promotion of protective factors, which we'll get into next. So the next slide. So connecting back to our earlier discussion on determinants of health, we want to point out a couple factors to remember. So we know that universities serve a diverse student body, and therefore it's critical for your staff and faculty to remain cognizant of the role that income, race, gender, and access play in the lives of your students and how it can be intimately connected to their educational outcomes. From a behavioral health standpoint, we also know that approximately 3/4 of lifetime cases of mental, emotional, and behavioral disorders begin by age 24. And so as you learn today, substance use disorders also oftentimes are seen among that population as well. So just something to keep in mind. And there is evidence that the behaviors adopted during this life stage are carried forward into middle and late adulthood. So this eliminates the role that you have as a campus community to really be critical in helping to prevent those later life health behaviors. Next slide. So as Taslim pointed out, resilience is huge with this. And we know that resilience is built during that 0 to 5, but it's not if you do have students or individuals that may not have had that resilience built up right during those early years, that doesn't mean that it's not possible. And so that is one of the big roles, and what we want to advocate for you all is really helping to support your university students with resilience building techniques. And there are a variety that are available, but just the role that you play in helping to support your students. Next slide. So coping skill development, and I know we're running through these just so that we can get through to some questions, but as we discussed earlier, stress is a continuum and does serve a purpose, but as a university system supporting students, and especially those who have a history of trauma in their coping skill development, will serve them not only as students at your institution, but then as they continue in their life and as an alumni as well. So when working with students, really focusing on hope is huge. So hope has been found to be a protective factor for youth from social, emotional, and behavioral disorders, and does correlate and predict the rates of many outcomes, including academic achievement. So helping to support them and really focusing on the why, looking down the road, being hopeful is really important for them as they move forward. Encouraging the students to try new positive coping skills and activities. It may take time to work with them on that, but that's going to be important, and helping them to establish things that are things that they're interested in. So providing them some examples, but asking those questions and kind of being humble. For the folks that are doing tobacco cessation work, using your motivational interviewing and shared decision-making training skills is going to be really important with this, because then you can work together with your college students that you're seeing to help them move forward with this. Particularly with the coping skill development and thinking about the COVID-19 pandemic that we're still in, it's really important to remember that a lot of the coping skills that may have previously worked for our university students may not be available, or they may be perceived as risky as well. So ultimately listening with empathy and working together with them who may be at higher risk for developing negative coping skills is going to be an ongoing challenge, but something that hopefully and we're sure you're up to the challenge for. Next slide. So lastly, so as we conclude our presentation, we really want to encourage you to think about what the student experience could be at University of Missouri with the adoption of some of these principles. And with that, we want to make sure we have 5 minutes for questions. And so want to turn that over to, I guess, Michelle.
Yes, thank you so much, Taslim, Aniela, and Amy, for such an informative webinar. You have shared a wealth of knowledge, and I know I learned a lot, and I'm sure others here have as well. I do want to now provide time to ask questions. So feel free to unmute yourselves or post additional questions in chat. I know Bill asked a question. Have you seen examples of using some of the state tobacco prevention funding to support the development and implementations of strategies to minimize and address ACES? And if not, do you think that there is a solid case to justify the use of those funds in that way?
Great. So I don't mind jumping in first, and then Aniela, if you have anything to add. So I haven't seen as much in terms of state tobacco prevention funding going specifically to these strategies yet. I see some states laying early foundational steps doing this. So the 2 states that come to mind are going to be Indiana and Pennsylvania, both starting to specifically look at and collect BRFIS data and then try to tie the BRFIS data around exposure to adverse childhood experiences with that of tobacco use rates in adulthood, and then work backwards on there and building sort of a justification and a use case as to why focusing on adverse childhood experiences is critical to preventing later adult use of tobacco. So one of the key suggestions I might give folks is to start thinking about how you might dig into the data in your state within the state tobacco prevention program and think through where you might want to build out some associations. I do think that there is a solid case to justify the use of those funds, and doing that only really because of what we talked about, which is that the dose response relationship between exposure to adverse childhood experiences, subsequent early initiation, particularly for those of you working with young people, and then subsequent adult use is one of the strongest associations we have as to what causes early initiation, duration, amount of smoking, and then adult use period and overall. So I don't know, Aniela, if you have anything to add to that.
No, that was great.
Thank you so much.
Yeah, I do have a question for you guys. I absolutely am really aware of the data that you've brought up, and it also, it not just leads to use of nicotine, but a host of other problems too. If you're a coach helping somebody quit smoking, and during the course of that process, the person does become emotionally, because of some memories or some issues pertaining to previous trauma events, do you have some guidelines to offer a person of, first, I've recognized like allowing someone to talk about that and getting them to talk through may be enough to kind of allow you to keep the process going for quitting, what would you use as signal to say, you know, this is great, and I'm going to help you get some assistance from a psychologist or a counselor? What are some thoughts on that?
Aniela, do you have something? I'm more than happy to jump in, but I want to give you.
Yeah.
As well.
So I think that the first thing is that's always, particularly around ACEs and talking about this for providers, is the fear that you're kind of going to open Pandora's box in this is always the big fear. But what they've found is that just asking and the acknowledgement that what happened to you really did matter, it was a big deal, is very healing for people. So you know, and then like you said, connecting them to then the appropriate resources to be able to go down that path towards healing. But just the acknowledgement that it's not just I made poor life choices or decisions is ultimately really healing for a lot of people. Taslim or Amy?
You know, Dr. Everett, the one other thing that I would add is oftentimes when we think about these trauma-informed principles around empowerment and choice, trust, safety, collaboration, so many of these things, being able to help folks within a responsible context, right, within a responsible treatment context and setting, understand also what some of the root causes of their health behaviors are, can be incredibly empowering as well. And if you are, you know, being provided with services and for the first time really being given the support to understand what might have led to early initiation and tobacco use for yourself, and then because of that, be able to have access to a number of different methodologies in order to best maybe make choices for yourself and for your treatment. We've seen some pretty powerful results because of that. I do think within each of these, you know, you want to make sure that who is providing interventions is really well matched with how you might integrate trauma into your approach, right? Like the difference between what might be a youth peer within a social support program, or peers, or you know, an actual behavioral health clinician or physician and such. So
yeah, there's some really great work out there being investigated around emotional processing to kind of take the place of the reward pathway that drugs do, and that people can be retrained to focus on positive emotional experience that ignites the reward pathway as a substitute for opioids or nicotine or whatever. And so I would highly suspect that folks who have had high levels of early childhood adverse effects have not had that pathway fully explored using kind of your more natural ways to use that pathway, and they quickly went to other substances as a way to get the reward we all kind of feel and want. And so I really think there's tremendous opportunity to make positive effect as you help someone quit smoking, potentially to address a lot of things that might bring reward to somebody who may not feel reward like a lot of us because of past experiences.
I would also add to really thinking about the cross-sector collaboration between your behavioral health departments and your coaching staff, right? So if you're thinking about somebody who's a coach being able to have that influence for the students, making sure they're really familiar with those that are in the behavioral health department and they're comfortable saying, I'm going to help walk you through this. And I'm going to send you to Aniela Brown, who is one of my really good colleagues. So that way it's a trusted messenger, right? Like if your coach trusts that behavioral health specialist, then your student is going to trust them too. So if you can find a way to have some cross-sector collaboration where you're introducing your behavioral health specialist to specific staff, that might be something that's really beneficial for you in the long run too.
Thank you so much for that engaging response. And I noticed that a few people came off chat. Lisa McLaren, did you have a comment or a question? There was also, and I don't, forgive me for the pronunciation or if I get the name incorrect, but T Salte also came off chat. Well, I recognize that we are over our time and want to thank everybody for staying on and for engaging in this content here. I really believe that you guys did such an amazing job, and I appreciate you sharing such a depth of knowledge here. I think that we've all learned so much and appreciate you and your time.
For those of you who stay on, I know that we're over time, so thank you. But my question, I was thinking a lot, and you guys might know, but just like the association between, tobacco and other substances and ACEs. And I'm sure that there's probably a lot of literature out there on that. So if people were interested in knowing more about substance use and ACEs, do you have a place to point them to?
Yeah, so absolutely. I'll go ahead and drop our network's website in the chat box. And just, of course, as you said, there's just such a strong association between other substance uses as well as ACEs. So feel free to, visit us there, and we can get you any information that you might need. If you're looking specifically for information at the intersection of ACEs and opioids, or ACEs and other substances, please just let us know, and we can get you some more focused information, materials, and training.
Thank you. I just know for me, it's been rather recently that I even really understood ACEs and the impact to substance use. So really appreciate it.
Thank you all very much. Really appreciate it.
I had one quick question, and if you don't have time, that's okay. But
No, Dean, please.
I know they're looking at there's a lot of information about the people who develop these bad habits or bad addictions because of their ACEs experiences. There's also a lot of people that have these ACEs that don't pick up these experiences. Are they looking at what makes some individuals more resilient than others, even though they've gone through these traumas?
Aimee or Taslim?
Yeah, sure. So of course, some of them, or Aimee, you want to jump in really quickly? I can, but I want to give you some room too.
Yeah, go ahead. I'll follow up after you.
Yeah, so I think particularly what we know is there's strong resiliency factors across multiple different domains of whether that's health or social engagement or interaction, right? So we know everything from strong positive relationships with caring adults can have huge impacts. We know, strong in the context of what we were talking about today, right? Really strong positive peer relationships can have really strong impacts. But so many of those other factors that I talked about at the beginning, which are those other social determinants, can really positively or negatively impact many of those other risks. And so what we're talking about oftentimes is a combined risk factor, right? That you might have exposure to adverse childhood experiences. In addition to that, you might have experienced a high amount of lack of access to behavioral health care and any other form of medical care. You might live in a place that doesn't provide you with those additional supports, et cetera. So what we also know is that when you have those really strong social determinants of health or positively associated determinants of health, they can really significantly mitigate many of the adverse childhood experience pieces. It's not singular, but I'm going to see if Aimee has anything to add from that sort of general as well as clinical framework.
Yeah, and I also think too, sometimes we forget ACEs don't happen in a vacuum, right? They also have a social context. And so when you're in, as a kid, you have these things happen to you, and then you go to school and you start having some acting out that people see, well, what's the thing that we do? We move that kid from class, right? So we're actually taking them away from something that was a protective factor. And so once we get them away from that, what could be good influence that is around that individual, we then put them in a group of people that become their new people, right? And they kind of feed off of each other. And if one has access to a specific risky behavior, substance or alcohol or whatever it might be, that's what the group is going to go with, right? And we continue to move those that have experienced any kind of adversity away from those protective factors. So thinking about that too. And I think Aniela mentioned that 0 to 5, that's a really big piece too to think about. Is resiliency is really built in those years from 0 to 5. And what happens if they miss that? So then really thinking about in your college years, okay, can we do some resiliency workshops, right? And begin to give some skills and things like that. Maybe it's just literature even that you could give out, or like a 15-minute pop-up, something that you could do too.
Thank you.
Yeah, I'm going to go ahead and drop in just a couple of like ACES are not destiny slide links as well that you can just look at for some basic framing and think through those if that's helpful.
Taslim, and I'm guessing that this is helping like for our providers to know where they might turn to find the best ways to help with resiliency and building those skills.
Sure. So again, like I'm just gonna go ahead and put my email in here. You know, thankfully at the National Council for Mental Wellbeing, we also have a trauma-informed, resilience-oriented department that really focuses on the ways in which to support both individuals, but also organizations, states, and other levels with just incredible support on how to both build trauma-informed systems, but then also how to really address trauma, knowing that oftentimes, you know, addressing trauma is now really an expectation, not an exception, and then really thinking about the ways in which to infuse that in every system that you might be working in. So I'll go ahead and put my email in the chat, and feel free to reach out to me and I can connect you to my colleagues working in that space.
And Bill, you're welcome to come off mute and share. I know that you put something in the chat box, so.
Yeah, so I've been working with coalitions across the US and Canada to create a free open source ACES and resilience resource commons for communities. And then we've created an ARC action network, and we just did a webinar on leading social transformations Michael Quinn Patton and others were part of that, and it was reviewing a peer-reviewed journal article on that same topic. And it was looking at a Canadian effort to dramatically reduce ACEs in the area of transforming the family justice system. But it's an example of really trying to systematically get at the underlying issues. This morning, I was working with another one of the groups participating in that ARC Action Network, and they're focused on how do you have early intervention even before a child is born in high-risk situations to reduce domestic violence and ACEs and trauma, where you can have a pretty good chance that it's likely to happen. So we're doing a lot of things to really push the envelope and have different coalitions across North America not have to reinvent the wheel as they're each working on different pieces of that. So I just shared a link in the chat to the webinar we did last week that kind of overviews that and how that approach can really help communities make a lot of progress faster on the underlying ACEs issues. And I'd love to get the work you guys are doing and have pulled together around the tie-in with tobacco included in that if you want to get it out to more people.
I love the ripple, right? Our work revolves around health centers. So I love to see when we can have it as a community, and then you have physicians to refer to that are trauma informed and looking at patients holistically. So thank you for sharing that resource.
You're welcome.
All right. I want to thank everybody and especially our speakers. Really great webinar. We will make sure to get this recording and the slides with the speaker's permission out to you guys afterwards. All right. Thank you.
Thank you so much.